So, Professor Maxim, since the latest RCTs, such as DISTAL and ESCAPE-MeVO, did not show significant functions benefit, and the device, the vascular vulnerability, and the risk of complications has been borne into the focus of the questions that should we remove or how to remove the thrombus in the distal and medial vascular.
Thank you for the question. I think it's a very important topic now. But based on your question, I want to come back to the last thing you said, which is how to remove the thrombus, right?
Yeah.
To me, I think that's the key, to how to approach this question. Because in your question, there is the implication that the thrombus needs to be removed.
Yeah.
Right? So where do we stand with that? The MeVO trials are what they are. They didn't show, as you know, a lot of trials. Results are not very encouraging.
Yeah.
On the
all
one
of them are negative.
Negative. Yes, all negative. On the one hand, but there's a lot to talk about. First of all, let's look at the broad history of endovascular treatment in general.
Yeah.
Right? If we look at what the history is and where we stand today, what does this boil down to? What is the sum total of our experience? The sum total of our experience, which by the way, started with also negative trials, right? The earliest trials were negative. Now, why were they negative? My opinion is that in general, if you look at the common sense, we have a blood vessel, right? That was opened. Now the artery is acutely occluded and the patient is symptomatic.
Yeah.
Yes. It makes complete sense that we have to reopen the vessel.
Yeah.
However it takes, remove the clot, stent, whatever it is. So the goal is to restore blood flow. That's a very, very common sense thing. Because a lot of people were saying at the time, if you go back, they were saying, no, we shouldn't treat them. That doesn't make sense.
Yeah.
What makes sense is if the artery is closed, we have to open it. Now, of course, it's very complicated. We have to open it quickly. We have to open it safely. So there's so many moving pieces. But ultimately, the conclusion of everything is you have a closed artery, we open it. Now, how much to open? The trials say that more open is better than less open. TK2C is better than TK2B, better than TK2A. That also is common sense. What about large core versus whatever? What is the common sense here? There's still brain to save, right? The bottom line is, even if there's a lot of brain that's already infarcted, if there is still some brain tissue that we can save, we should try to do that. The returns are less, of course, the number needed to treat is more, it gets a little more complicated. The recovery numbers are not as good, but in general, it still makes sense, right?
Yeah.
Okay, so now we're gonna take this, we're gonna apply it to the MeVO. Yes, there's issues. How do you define what is good? Is it NIHSS? Is it whatever? In my opinion, there's no magic transition between an M1 and M2, which is also controversial. We have a closed vessel with a symptomatic patient.
Yeah.
We have to open this artery. Now, we are not, what the trials in my mind show is that the devices need to be better, the times need to be better. The trial design with the patient selection to ensure lack of absence of bias, the cherry picking that we talk about, right? Basically cherry picking is taking the clinically better patients and putting them in the control arm and taking the bad patients and taking them to thrombectomy, randomize. So how to randomize without bias is all important. So we have to get the devices have to be better. Our techniques have to improve. The benefit is perhaps less.
Yes. Because
there's less brain to save. But on the other hand, you can think of it that way. But for somebody who is a person who is working, highly functional, even a small reduction in their capacity is already can be very bad for their, for their everyday, for them, for their loved ones. I think
for the families.
Ultimately, my prediction is that ultimately the vessel will have to be open. Now, maybe there's better medication that can come around. If we can open it with medication, of course it's
much better.
Of course. So yes, but it has to be something that opens this artery with enough safety that the risk benefit now tilts towards.
We have to balance the effects.
We have to balance. And in MeVO, still like the efficacy of TPA or TNK is still a little bit low.
Yeah.
Right. So we have the medicine is not the solution at the moment. We need either a different kind of medication or we need a better endovascular approach. So I think we have to keep moving towards that.
Yes.
Personally, like our strategy in our hospital, we continue to do MeVO.
Yes.
Maybe we're a little bit more selective.
You will prefer to some aggressive method?
I think so. We continue to do MeVO, like especially if it depends on the overall status of the patient. So of course, like sometimes like it doesn't make sense. So we are selective now at this stage in whom we do and whom we don't do. Yeah. But I still we prefer, if we can, to open the artery. Okay. So we can talk even more about that, but that's in a nutshell. I think we're going to continue moving that way. And at some point,
we have to move forward.
We have to move forward, and we have to arrive at the point where we're like, okay, like now we are ready to do this again.
Yeah.